which is made by the liver called plasminogen. Plasminogen is actually sitting inside the clot, but it's not active. Okay? So it's kind of wrapped up in there with the fibrin, but actually needs to be activated. So what happens is that TPA, so TPA is naturally occurring in the body, and probably what you guys have heard of is TPA is something that we give as a drug, right? Hold on a second. That's all right. TPA is.
Yeah.
Okay.
You see them? Okay. That's why.
Yeah, that fly was huge.
It's bad. That's your pet.
So the plasminogen is in the clot, but it actually has to get activated by something. So tissue plasminogen activator and urokinase plasminogen activator are always floating around in the body to some extent, but in small quantities. And they're naturally inhibited all the time by other factors until they're basically told, okay, it's time for you to act, okay? So once it's time for them to act, to actually break a clot down, the inhibitor that's normally bound to it actually detaches. And the TPA or UPA, urokinase plasminogen activator, or tissue plasminogen activator, actually are able to be activated, then bind to fibrinogen inside of the clot, and then change that plasminogen into plasmin. Plasmin actually works to cleave apart those fibrin strands. So remember that last part of the coagulation cascade, right, as part of the common pathway, fibrinogen and fibrin, basically fibrinogen to fibrin forms those cross-linking bounding cross-links, and plasmin actually goes and cleaves those apart, breaks them apart, to actually start the process of allowing the clot to dissolve, okay? And so when that happens, fibrin split products are released from the clot, okay? So you might see it called FSPs or FDPs, fibrin degradation products or fibrin split products. And D-dimer is a measurement of that. So who here has ever heard of a D-dimer? Okay, so what's a D-dimer used for?
I thought it was to check for like DVT.
Okay, so it's used to check for DVT. How can we make sense of that logically? What would the relationship to a DVT and a D-dimer be? So if a D-dimer is a measurement of the fibrin split products. Go ahead, Miriam.
Oh, I was just trying to think. So you're saying that D-dimer is a split product from the fibrinogen or fibrin?
The fibrin.
The fibrin. So.
Yeah.
That's what's going. So that's pretty much what's breaking up the clot, right?
So if this is the clot, right? This is the clot.
Right.
Then what happens is plasminogen is living in here, right? It's produced by the liver. Something happens, right? So there is the binding, right, of TPA or UPA to the plasminogen in here that is bound to the fibrin. Once that TPA comes and binds to that, it actually activates the cascade for plasminogen to turn into plasmin, okay? Once it turns into plasmin, then the plasmin kind of starts chopping it up. And then you have all these little fibrin split products. So the clot is no longer this one happy little clot. Now it's basically being like chopped up, karate chopped, okay?
So the
So
slow
then
presence of a clot because there's acidic or plasmin, it's detecting that. So pretty much it's saying like, all right, you have a clot going on.
Right, so it's saying, like anytime our body has a clot that doesn't belong there, right? So let's say I develop a DVT. My body is automatically going to start trying to break it down because it doesn't belong there. It's impeding blood flow to the rest of my body or impeding blood flow back. So naturally when we form a clot, this process is going to be happening to some extent And this process is happening to some extent in our body all the time when we have just little injuries, like when we brush our teeth or, bang our elbow, or just naturally, this is always happening to some extent. But when you have a big clot that's formed, it's happening to a larger extent, right? Because the system is activated. So if you have a large clot and the system is activated, it's constantly your body's constantly trying to break that clot down. And when it's trying to do that, it's releasing these fibrin split products. D-dimer is a measurement of that. So if you have a clot in your body, a large clot, something like a DVT or a PE, you will have, most likely, an elevated D-dimer. Okay? Yes?
Can that be false if you have like really big bruises?
It can be false for a ton of reasons. Can you think of some?
Big bruises?
Okay, so recent trauma, right? So any recent trauma, any really inflammatory state can increase the fibrin split products to some extent, okay? So anybody that has cancer, has a recent injury, a recent surgery, an inflammatory illness or autoimmune illness, a D-dimer is not a reliable measurement, really, okay? Because they're gonna have elevated fibrin split products all the time. So it's a great test for somebody that we have a low suspicion for them having something like a DVT or PE. And we want to not do a CAT scan, right? To need to rule out a pulmonary embolism or an ultrasound to rule out a DVT. Like an ultrasound's really not a big deal, it's cheap and easy. But let's say for most people, the reason why we do a D-dimer is we don't want to put them at risk of getting a CAT scan with radiation and contrast to evaluate their pulmonary arterial system. So what we'll do is get a D-dimer, but it's really only helpful in a patient that we have a low suspicion for. Because if we have a medium or high suspicion, the specificity and sensitivity of the test kind of goes out the window. But that's why we use a D-dimer to help us figure out what the likelihood of somebody having a DVT or PE. So if Emmy came in and she said, my left calf really hurts and I'm having trouble walking, and she has no other symptoms at all, she would be a great person to get a D-dimer in rather than doing anything else. And if the D-dimer was negative, I could say, I'm almost 100% sure, 95% sure she doesn't have a DVT. Okay? Somebody that comes in that's pregnant or has cancer, probably not a great test to use in them. Okay? All right. So plasmin, in addition to degrading the clot, actually inhibits the clotting factors from continuing on. So it inhibits the remainder of several clotting factors, 5, 8, 9, and 10, from continuing to be active. I liked this little diagram. We didn't really talk about like natural inhibitors of plasma or plasmin, but this is a good little diagram to kind of remind you that we have the TPA and the urokinase. These guys are the inhibitors that circulate with them all the time. Once a clot forms, this guy kind of falls off, and these guys are active. They actually bind to plasminogen, which is fibrin bound, and actually help that formation of plasmin. Plasmin then breaks apart the fibrin clot that is formed, and it results in fibrin degradation products. And then you get the further inhibition of fibrin. All right. So let's talk about how this is even clinically relevant. So fibrinolytic therapy is something that is used, I would say, probably frequently if you work in the emergency department, but even in the emergency department on a scale of the things that we do frequently, it's fairly infrequent. So we're using it to actually lyse or break apart thrombin-rich clots that have formed in the body. So can you think of some reasons or some places in the body where it would be really important to be able to bust a clot? In the heart, in the brain, and in the lungs. Right? Those are probably like the most important 3 areas that we really need to be able to bust apart a clot. Because if we don't, right, especially an arterial clot, that's what we're talking about arterial really now, is that we're going to lose blood supply to vital tissue that's supplied by that vasculature, right? Okay. So areas where ischemia is life-threatening, as you mentioned. So you can see here, right? So this is one of the coronary arteries. Which coronary artery is it?
that
Is
should
it
be
the
the
left?
left.
Right, because the right
Yeah.
doesn't branch for a while, right? So
Right.
this is the left main, okay? So this is before it branches into the LAD. Okay, so you can see here, this is a, remember we talked about PCI or percutaneous coronary intervention? This is percutaneous coronary angiography. Okay, so angiography is done before we would go in and put a stent or balloon in to actually diagnose, does the patient have coronary disease, and if they do, how severe is it? So you can see here, this is a normal filling, right? This is contrast inside the vessels. So you put a catheter in and you inject contrast, so you can see the contrast kind of backflowing here, and then you take a picture. And it tells you where is the contrast filling and where is it not filling, okay? So that would be a good reason why you might do thrombolysis on somebody. So why would we do thrombolysis if we have percutaneous coronary angiography? So in a patient that has a MI, why would we do thrombolysis if we could just do percutaneous coronary angiography?
It's faster.
Okay, so we only are going to do it if there's a delay in getting somebody on the table or to a center that can actually do percutaneous coronary intervention, okay? If we don't want to use thrombolytics unless we have to, okay? So time is of the essence, right? So we need to really evaluate how quickly can you bring a patient to a center that can perform this. And if it's going to be delayed, then you would consider thrombolytic therapy, right? So the general recommendation for stroke patients is that you have to do thrombolysis if the symptoms have been, the onset of symptoms have been less than 3 hours. There's some studies which are now showing you can kind of push it a little more, about 4.5 hours, it's still efficacious. For an acute myocardial infarction, pretty much door to balloon time, you really want to be as fast as possible. So some places will say 90 minutes, some say 60 minutes. And for patients that we cannot get to PCI because they live in a rural setting, they can't be transported to a place that has PCI, then fibrinolytic therapy should be administered as early as possible. So the faster that you do it, the less chance of mortality that the patient has. With that being said, unlike a stroke, for an MI, you can use fibrinolytic therapy up to 12 hours after the onset of symptoms. But again, the faster the better, right? The longer the time that that tissue is ischemic, the worse off that the patient does and the more complications that they're going to be at risk for. Generally, we use this for ST elevation MI, not non-ST elevation MIs. Why is that? Generally, non-ST elevation MIs are patients that have chronic disease, not an acute occlusion that happens. That the clot tends to be made of different stuff. So a patient that has an atherosclerotic plaque that kind of over time is collecting clot or disease is going to have more collateral circulation versus somebody that has either a plaque rupture or has an acute thrombus to one of the main vessels of the heart. That clot is going to be more amenable to thrombolysis or fibrinolysis based off of the actual components of the clot itself being more thrombin-rich versus more platelet-rich, although both are going to have platelets. All right, this is an example. So can anyone see what's wrong here? So where are we?
Superiority of the heart and
So it is the thorax.
yeah,
So this is the vertebrae,
right.
right? What is this?
Sternum.
These are the ribs. Okay, what's this?
Heart.
Good. What's this?
Is that the?
Good. Yeah. So this is the pulmonary trunk.
Yeah.
The pulmonary arteries. Okay. So what do you see?
Blood in the pulmonary trunk.
Show me where the blood is.
The white.
So the blood is the white, right? So this is the white. What's the gray? So normally the blood doesn't look white like that. We gave them something to make the blood white like that in contrast, right? And then we see this gray area. So everything's white, and this is gray. It's not filling. That's where the clot is. So this is called a saddle embolus. Okay, it's a pulmonary embolus that saddles both the right and left sides of the pulmonary arteries. And it can be fatal, obviously. And then you can see down here, this is the scout image on the CT. This tells you at which level that you're actually looking at on the cut. You guys are gonna have radiology next semester, so you're gonna learn how to read this stuff.
Point that out again for me, I missed it.
This is a scout film right here down in the right-hand corner.
Oh, the bottom one.
So this tells you, right, it's kind of like an x-ray that tells you basically at what level you're at, right? So you're basically right at the level where the aorta and the pulmonary trunk are coming off of the
Okay, you call it a scalp film.
scalp film. Yep, scalp.
Okay.
So scalp meaning just like a quick look telling you where you are
Mhm.
on the like an external.
I got you.
Okay. So what are some contraindications to using fibrinolytics? As you can imagine, bleeding, right? So if the patient is either had a recent major bleeding event or is actively bleeding, you don't want to use fibrinolytics. That makes sense, right? If the patient has a high risk of bleeding, something like an arterial venous malformation, such as something in their brain or in their lung that is at risk for bleeding, and then recent trauma. So anybody that basically is actively bleeding or has a risk for bleeding. Okay, so if the patient's had a recent intracranial hemorrhage or ever had an intracranial hemorrhage, their risk of bleeding will be much higher than someone that has not had that before. And fibrinolytics, as it is, have a fairly high risk associated with that. Okay, so do not memorize this, but I do want you guys to at least review and read through. I'm not going to stand up here and read it to you now, but there are some absolute contraindications and relative contraindications to using fibrinolytic therapy. What's the difference between an absolute and relative contraindication?
Absolutely, it's like you don't want to get.
Absolute is no, no way, never.
Yeah.
If you do it and then something bad happens, there's no justifying it, right?
Right.
Versus a relative.
It might.
Use caution,
Yeah.
right? But it really depends on the patient, and you need to let the patient know of the risks associated with using it, right? So in a lot of these cases, we're talking about like life and death, right? So we have to weigh the risks and the benefits of, you know, if we give you fibrinolytic therapy, you could have a life-threatening intracranial hemorrhage. However, if we don't give you fibrinolytic therapy, you know, you may have this hemiplegia for the rest of your life from a major like MCA stroke or something, right? Okay. So there are three main types of fibrinolytics that we use. So there's TPA and UPA. So those are actually normally made in the body, right? We talked about those being stimulators of that conversion of plasminogen to plasmin naturally in the body. So just like a lot of these other things, right, that naturally occur in the body, we've now made recombinant versions of those that make them kind of work like the natural component in the system, but like on steroids, right? And then in addition to that, there's streptokinase. Streptokinase does also exist in the body, but we actually now have been able to recombinantly make it in the lab using Streptococcus. All right, so TPA is the most common one that you'll probably see. It's been around forever. It was the first fibrinolytic that was made. It is pretty selective for activating fibrin-bound plasminogen. So what does that mean? Right, so there's plasminogen in the body circulating all the time. But we're talking about that plasminogen that's actually stuck within that fibrin meshwork that's inactive, right? That's really what we want to target. We don't want to target all the active plasminogen in the body and convert that to plasmin. That sounds like a disaster waiting to happen, right? So we do really want to try to target this as much as we can to the areas where the problem is. So that's one good thing about TPA. It actually binds to the fibrin at the surface of the clot and activates that plasminogen that's bound to plasmin, and then allows for cleavage of the fibrin molecules that are kind of all stuck together. So this is a little diagram that kind of talks about what we just talked about, forming fibrin split products or fibrin degradation products after plasminogen is activated. Where's plasminogen made? Good. So indications for use, we can use it for myocardial infarction, CDA, that is thrombotic. It's really important to differentiate when we talk about stroke from ischemic and hemorrhagic, right? So hemorrhagic stroke, this is an absolute contraindication for use. A thrombotic stroke, obviously, is a different story. pulmonary embolism or catheter occlusion. So probably the most common reason why we use TPA in the medical setting is actually to bust clots that form in lines like PICC lines or dialysis catheters. So you can actually put a little small amount of TPA, like 25 cc's, into the catheter itself and let it sit there for 30 to 45 minutes. Let it actually break apart any fibrin that's kind of collected in the catheter, and then you suck it out. All right, so it's such a small amount, but that's probably like the most common reason why we use it, or you might see it being used in the hospital. Even if that small amount of TPA got injected into the patient's body, probably like a negligible amount versus the amount that we give when we're giving like thrombolytic therapy. Yes.
So when people have ischemic strokes, is this the clot buster?
Yes.
Okay.
Yeah, it is. Who are you gonna call?
Yes.
Yes. So, major adverse effects, as you can imagine, of thrombolytics or fibrinolytics, both the same thing, is bleeding. So even though, like we said, well, this one's really selective only for clot bound, yes, to some extent, but it still is going to have an effect on the systemic state and is going to cause some unwanted fibrinolysis throughout the body in areas that we didn't intend for it to happen. Okay, so there's quite a significant risk in using fibrinolytics. So we're really only using it in patients where there's a life-threatening thrombosis. Okay. So these are the three formulary or like available pharmacologic compounds that are TPA, basically. So alteplase is probably the most common. Retaplase is also pretty common. And then I haven't actually used tenecteplase ever. They're a little bit different from one another based off of their half-lives. The half-life generally tends to be pretty short. You want it basically to do its job, but not stick around for too long. And they all have a little bit different of an indication. Tenecteplase is only used for acute MI, whereas retaplase is used for AMI and pulmonary embolism, and alteplase can be used for MI, PE, and CDA. So streptokinase is kind of interesting because it's actually derived from strep bacteria. So we talked a lot about strep bacteria, and what was the take-home thing that you learned about strep bacteria last week? So we talked about a lot about group A strep, and what did we learn about it? Just if you had to give me like a one-liner. What? Can lead to other stuff. Why? What? So it's not so much the spreading, right? Because even if we have a pharyngitis where the infection is localized to the throat, it wreaks a lot of havoc, right? How does it do that? The word's up there. So it's very antigenic, right? So it causes an autoimmune response oftentimes, right? And where it actually causes antigen-antibody complexes to form in the body, right? Which cause rheumatic fever, pandas, glomerulonephritis. So similarly, I want you to kind of frame your mind around what we already know about Streptococcus bacteria. Now we're making a compound to actually cause fibrinolysis with this bacteria that's pretty antigenic. So streptokinase can be used for the same indications that we talked about before, adverse effects, bleeding, of course, and then anaphylaxis. So streptokinase that occurs naturally.
Does the same thing happen with insulin?
No.
Or is that because it's from E. coli?
So most insulin is porcine derived. There are several drugs, and I'm not sure if insulin is one of them, that can also be made from E. coli, but E. coli tends to be also very antigenic. So there's a chemotherapy drug called asparaginase that we use that's E. coli derived, and like its biggest side effect is anaphylaxis. Yeah, so a lot of these drugs that are derived from bacteria can cause an antigenic response in the host and cause like an immune phenomenon, okay, where the body actually forms antibodies against this antigen complex. Okay, so in streptokinase, unlike TPA, it's not as sensitive to the fibrin that's actually inside of the clots. But what we noticed about streptokinase is that because it is made from the Streptococcus bacteria, it actually has the propensity to cause antibody formation. So when you think about it, it's really not that much of a problem on the first time around, right? Because you give the drug, the half-life is fairly quick. We're looking for a fairly quick result, right? A thrombolysis of this big clot either in the pulmonary artery, the coronary circulation, or the brain, right? But what happens after that is that if the patient or the person has a host immune response where they form antibodies to the drug, those antibodies are going to stick around for a while. So we need to be mindful of that. Why?
That causing the allergic reaction.
Well, it can cause a type 1 hypersensitivity, like anaphylactic reaction, but generally it's not a type 1, right? Generally this is a delayed reaction for the body to form those antibodies, like a type 4 reaction, right? So that second response, if the patient were to get to get streptokinase again, then they could have a much more severe antigenic response, like anaphylaxis for sure. But one thing is there's cross-reactivity between, if the patient had a recent strep infection, they have antibodies. The antigen, you're basically giving them the antigen, so you're giving them streptokinase. If their body has formed antibodies due to a recent strep infection, that same antibody-antigen response can happen when you give the streptokinase, okay? So you can actually induce a whole host of immune phenomenon, just like we talked about recently with a strep infection. And worse being an actual anaphylactic reaction. So obviously it's a little bit less desirable. Lastly, we have urokinase, which again also exists naturally in the body. It's very, very expensive, which is why we don't really use it much. It's formed, its natural complex is formed by the kidneys. And it's really circulating in a very small amount. So TPA is generally actually dealing with our intravascular clots that are happening. Urokinase or UPA that's occurring naturally in the body is generally helping break down clots that are extravascular. But in this case, in treatment, using these for treatment, the compounds that are basically man-made compounds are always used for intravascular treatment. Okay, but how it actually works in the body naturally is that TPA is mostly dealing with the intravascular component, whereas urokinase or UPA is mostly dealing with extravascular component. This also, so just like, remember, so TPA is pretty specific to the clot-bound plasminogen activating versus streptokinase and urokinase, a little bit less specific. So it's acting on not just breaking down the fibrin that's actually active in the clots, but actually also inhibiting fibrinogen and fibrin formation throughout the rest of the body. So can lead to more increased risk of bleeding, and it's very, very expensive. So we don't really use it too much. This is a great video that you can watch if you have some questions still about kind of how this all goes down. And naturally in the body, when this is all happening, right, without that exogenous, without talking about the therapeutic use of the pharmacologic agents, this is all happening naturally in the body. All of these compounds are mostly being released from the endothelial surface of the cells, okay? Or of the vessels rather, not the cells. In addition to that, I want to mention, so those are our fibrinolytic agents. But the question is what do we do if we have a patient that we give a fibrinolytic to, and now they're bleeding? So there are some anti-fibrinolytics that can be used. We want to be really careful about using these in the setting of bleeding in areas that, if there was clotting, could potentially cause a major issue. Can anyone think of one area in the body that, let's say I'm your patient, I have a myocardial infarction, I live in Timbuktu, I can't get to a hospital to actually have percutaneous coronary angiography. So you give me fibrinolytics, and now I start bleeding. And now you want to treat that. So you're going to give me an antifibrinolytic. So what does that do? It actually binds to the plasminogen molecule and stops the ability of that plasmin to actually work. Okay, so it inhibits plasmin once it's already been activated. So if I had bleeding in what area of my body mucosal area of my body, could inhibiting that be a problem? What's that?
Somewhere in the GI tract?
So the GI tract, we think about the lumen of the bowel, right? So if you were bleeding and you inhibited it, the peristalsis of the bowel, generally the caliber of the bowel is not going to be like completely occluded by a clot, right? Because just like stool, it's going to kind of pass through, right? What else? Yes, so I'm your patient, you gave me fibrinolytics, and now I'm bleeding. I'm oozing from everywhere. My mouth, my nose, my vagina, my buttocks, my urine, everywhere. So can you think of a place where it would be really dangerous to then give an anti-fibrinolytic to reverse that effect, to block that effect in plasma? So remember, if you do that, it's going to cause clotting, right? For any area that's bleeding, it's going to cause clotting. So of all the areas I just mentioned that I'm bleeding from, where if you stop that bleeding and make it clot, is it a major problem? Yes, in your kidney, right? So the urothelial system, anywhere in the urothelial system, the ureters, right? The urethra, the bladder, because those tubes are really small. So if you clot those off, there ain't nothing you can do. Right, so there's only one way to bypass if the kidneys, the ureters get all clotted off. There's only one way to get the urine out. You know how? Put tubes directly into the kidneys to the outside world called nephrostomy tubes. So, if you are going to give antifibrinolytic therapy, which I've given many times to patients with really severe thrombocytopenia, let's say going through bone marrow transplant, they're Jehovah's Witness, they won't accept any transfusions, and they're having a lot of mucosal bleeding from the mouth. You always have to get a urinalysis to make sure they are not bleeding from their urinary tract before you give an antifibrinolytic. Because if you clot off their urinary system, they're basically screwed. Okay, and there's only one way to reverse it, and that's putting in nephrostomy tubes until the clot's clear, which can take a long time. Okay, so just be very mindful of that. But we can use it for patients that have mucosal bleeding, hemophilia, patients that won't accept transfusions and are thrombocytopenic. And can be used to reverse the effects of fibrinolytics. Of course, if we give a fibrinolytic for a patient that is requiring fibrinolysis for a major life-threatening clot, giving antifibrinolytics after that obviously could be detrimental, right? So you're always managing the risk of the patient dying from whatever is happening at that moment. So this is really, can be helpful in patients that have life-threatening bleeding, but also is kind of always this controversial conversation we have about, risk of clotting it as well. It can be given orally and intravenously. For mucosal bleeding of the mouth, Amicar can be given as a swish and spit, which is really helpful because it's really not much of it is systemically absorbed. It actually will act topically, so that can be sometimes helpful. Intravenously, it's given every 6 to 8 hours. Of course, the adverse effects can be thrombosis, and you really want to use extreme caution or don't use at all if the patient has bleeding in the urothelial system. Okay? All right. So what part of the coagulation cascade does TPA work on, Los? What's that? Well, we can say that the factor first, and then we can determine which part of the coagulation cascade it works on.
Factor one?
So it's acting on fibrin, right? Okay, so what part of the pathway is that? Intrinsic, extrinsic, or common? Good, common, right? Very good. All right, so what lab test might suggest increased fibrinolysis, Crystal? Oh, the D-dimer? Very good. Very good. D-dimer, fibrin split products. What does an elevated D-dimer indicate, Kiera?
The elevated fibrin product.
Very good. Elevated fibrin split or fibrin degradation products. I just said what that is, so I gave the question away. All right, Duyan, tell us about this case. So read it out loud.
What should I,
Oh,
oh. You are caring for a 75-year-old female with a history of
Hyperlipidemia.
hyperlipidemia, hypertension, and ischemic stroke about 6 months ago. She presents with severe chest pain and ST elevation in leads 2, 3, and ABF. You are in rural Alaska and you are several hours from a center with access to PCI.
Okay, very good.
So
So what do you do?
it's a STEMI, right?
Okay. So she has ST elevation, so that's a STEMI. Very good.
You give fibrinolytics.
Okay, so you want to treat it with fibrinolytics?
Mona.
No, you have PCI.
Well, we're
you
7
have-
But
hours
zero
from
hours.
that PCI. Okay,
Yeah.
all right. All right, so who wants to treat the fibrinolytics? Okay, who wants to let the patient die? All right, so you look in the pharmacy. and
Wait,
you
question.
notice- Yes.
Oh, go
Yes.
ahead.
I have a question. Can you also do Mona on top of
Absolutely.
Okay.
Absolutely. What's Mona? Tell your
Yeah.
class what Mona is.
morphine, oxygen?
It's not just like a little old lady that
Mona Lisa. Show the picture. Morphine, oxygen, nitroglycerin, aspirin.
Very good. Yes, absolutely. So the aspirin is, if you're going to use fibrinolytics, kind of like, yeah, do you really need to use aspirin?
Yeah.
But definitely the rest for sure. Okay. All right. So you look at the pharmacy, you notice that the only fibrinolytic you have left is streptokinase. So what risks do you want to discuss with the patient, Eden?
So, does she get more whole clots or and then MI and
So you were saying,
risks?
so what are the risks of giving the streptokinase? What's that? Okay, so any recent strep, which like probably unlikely in a patient that's older, right? At least group A strep, maybe like they could potentially have had some other strep infection, but taking a good history will help us figure that out. What else?
Is it
So risk of anaphylaxis, okay?
bleeding because it's less
Definitely
selective?
bleeding, right? Definitely bleeding anytime you give a fibrinolytic, but even more for streptokinase and urokinase because they're not as specific, right? For clot specific. Plasminogen, okay. What else?
Does that do something with the antigenic like property?
Right. So at least that, like her knowing that there's a potential, right, for her to have an immune response, right, and that future exposure to streptokinase should be avoided, right? At least in the 6 months after streptokinase. Okay. Good. Anything else?
You guys ever do something this
What's that?
Has she taken it before?
No, she's never taken it before. So, and then we also want to look at the relative and absolute contraindications for actually using a fibrinolytic, right? Yes.
Did she have a strep before?
So, no, she's had no history of strep recently before that she knows of. But what does she have a history of that we want to at least be sure that we look into and assess? So definitely hypertension, right? So a relative contraindication to using fibrinolytics is severe uncontrolled hypertension. I think the actual number is 180 over 100. It's a relative contraindication to use. She also had her ischemic stroke 6 months ago, right? So a hemorrhagic stroke is an absolute contraindication to using fibrinolytics. Ischemic stroke is not necessarily, but sometimes ischemic stroke can become hemorrhagic, so we definitely need a little bit more information. But yes, very good. So you want to make sure you're always discussing the risks associated with the drug that you're giving to the patient and letting them know what they are so that they can make an educated decision.
I just have a question.
Yes?
So all the information on fibrinolytic, like the overarching information that you gave applies to streptokinase, all three of them? Or
So all the overarching information that I gave applies to all fibrinolytics.
Okay.
Okay, and then I specifically briefly talked about each of the
Okay.
3 fibrinolytics, well, each of the 3 types,
Okay.
right? And then there's 3 types of TPA that have little variability within them. Just so that you guys know like what's available and what's the like the major differences between them. Yeah. Okay, good. All right. We're cruising.
Are we starting paint?
We are starting hematopoietic thrombectomy.
Can we pee really quick? Should we start?
Of course. Run!
The no hers look like yours, so she was like.
Is anyone else depressed that it's like been getting so dark right now? It feels like.
I love it.
I was like, I would tell I like to play volleyball after work.
Play softball.
I used to play indoor and when I lived in San Diego, but the problem is with the adult games is they're so late that like I don't want to go play, like I'm kind of winding down at 9, 10. I don't want to go play 9, 10, 11 o'clock. I just can't go into that. But like at 6,
Yeah, oh, we get one for school.
yeah, that's great. And you play outdoor and, okay. And the field's smaller than at 11 on 11?
Yes. I have an 11 on 11. That's me on softball.
She did.
Well,
you were able to like drag it along.
I don't know.
I thought you
Oh, no, I wish. I wish I could
When are we gonna like sign up for our classes?
They don't give you a refund.
Next week.
Oh.
I ate $700 for it.
You're looking forward to next semester?
Oh, I just want to know my plan when I'm going.
You want to what?
I want to plan like how I would be able to go